All right, welcome to your deep dive. It seems like you're prepping for the TNCC exam,
That's right.
and you've given us a really interesting set of study materials.
Absolutely.
A lot from Quizlet.
Yep.
So we're going to kind of go through all this and help you really understand what you need to know to ace this exam, but in a way that's interesting.
For sure.
Not just like flashcards.
That's the point.
So,
The TNCC is all about applying the knowledge in actual trauma situations.
right.
So it's not just about rote memorization.
Yeah, and that's what I noticed about these Quizlet sets that you gave.
Okay.
There's a lot of different question types.
Mm-hmm.
You know, there's true or false, there's multiple choice, there's even matching.
Oh, yeah.
And the content's all over the place, from airway management to spinal cord injuries to shock.
Right.
It really seems like they're going to test your ability to think on your feet
Absolutely.
and apply these concepts.
You got it.
And speaking of real-life scenarios,
Yeah.
I really like that you sent over these case studies because they make it so much more vivid and engaging.
For sure.
Like there's one about a 2-year-old that fell out of a second-story window
Oh.
and another one about a drunk driver in a car crash.
Yeah.
So,
That's good stuff.
yeah, it's intense.
Intense stuff. Yeah.
Um,
And case studies are such powerful learning tools.
yeah,
We will definitely be dissecting those throughout this deep dive
right.
to really illustrate these points and see how it all comes together.
Okay, so the first thing that popped out at me in your study guides
Mm-hmm.
was the trauma triad of death.
Okay.
That sounds pretty dramatic.
Yeah,
And it's definitely something you'll want to know for the exam.
for sure.
So what is that all about?
So the trauma triad of death refers to the deadly combination of hypothermia, metabolic acidosis, and coagulopathy.
Okay, break that down for me.
So imagine a patient
Yeah.
who's been seriously injured and is going into shock.
Okay.
Their body temperature starts to drop.
Uh-huh.
That's the hypothermia.
Yeah.
And that throws off the balance of acids and bases in their blood,
Okay.
leading to metabolic acidosis.
That makes sense.
And then as their body gets colder and more acidic, their blood's ability to clot properly goes haywire.
So it's like a domino effect.
Yes.
One thing goes wrong and
Yeah.
all just spirals out of control.
Exactly. That's why it's called the triad of death.
Right.
It's a serious complication that we need to recognize and treat very aggressively.
And speaking of recognizing it,
Yeah.
I noticed one of your Quizlet questions focuses on serum lactate
Mm-hmm.
as a measure of this.
Right.
Why is that so important in trauma?
So think of serum lactate as kind of a smoke signal from the body's cells.
Okay.
When cells aren't getting enough oxygen,
Mhm.
which is called hypoxia,
Right.
they switch to a backup energy system,
Okay.
and that produces lactic acid as a byproduct.
Interesting.
So a high serum lactate level
Mm-hmm.
basically tells us that there's something wrong with the patient's circulation and oxygen delivery.
Okay. So high lactate, bad news.
That's exactly right.
Got it. Now, something else that I saw in your study materials is the emphasis on airway management.
Right.
There's a lot about different interventions like oropharyngeal airways,
Mm-hmm.
bag valve, mask ventilation, even cricothyroidotomy if intubation fails.
Yeah.
Like, why is that so important?
Airway management is absolutely crucial in trauma
Right.
because a compromised airway can quickly lead to death.
Yeah.
We have to be able to act fast and know which intervention is appropriate for the situation.
Like that case study with the 2-year-old who fell out the window.
Mm-hmm.
I remember it stressed that airway assessment should be like the top priority
Absolutely.
in that scenario.
Especially in children, they're
Yeah.
very vulnerable to airway compromise
Right.
because their airways are smaller and more easily obstructed.
Okay, so what about,
Yeah.
like one of your questions said, if the patient's unconscious and they're breathing, but they have these snoring sounds?
Yes. Those snoring respirations are a classic sign of an obstructed airway, usually caused by the tongue partially blocking the airflow.
Okay.
So in that case, you'd want to open the airway using a jaw thrust maneuver or head tilt chin lift,
Mm-hmm.
assuming there's no concern for a spinal injury.
Right.
And then you could insert an oropharyngeal airway to keep the tongue from obstructing the airway.
Makes sense, but what if that's not enough?
Then you would need to assist their ventilations with a bag valve mask.
Okay.
And in really extreme cases, if intubation fails,
Yeah.
a cricothyroidotomy might be necessary to establish an airway.
Wow, that escalated quickly.
Yeah, that's trauma care.
Okay.
You always have to be one step ahead
Yeah.
and ready to escalate interventions if needed.
Speaking of intense,
Yeah.
there was one question that really surprised me.
Okay.
It was about priapism being a suspicious finding in a spinal cord injury.
Interesting.
What's going on there?
Yeah, it seems counterintuitive, right?
Yeah, why is that a red flag?
But priapism, which is a persistent and often painful erection, can actually be a sign of neurogenic shock. Really?
Which can occur with spinal cord injuries.
How does that work?
So it's all about the disruption of those nerve signals from the spinal cord.
Okay.
In neurogenic shock, there's a loss of control from the sympathetic nervous system, which normally helps regulate blood vessel tone.
Right.
And this can lead to widespread vasodilation, which causes a drop in blood pressure.
Okay.
And at the same time, the parasympathetic nervous system, which controls things like bladder and bowel function, can become overactive.
Okay.
And in some cases, that overactivity can lead to priapism.
So it's not just about like physical trauma down there. It's a sign of something wrong with the nervous system.
It's a sign of a much bigger problem.
Okay. Wow. Definitely going to remember that one.
Good.
And while we're on the topic of spinal cord injuries, I saw that your study guide also talked a lot about the log roll maneuver.
Right.
So what is that all about? So the log roll is a technique we use to move a patient with a suspected or confirmed spinal injury while maintaining spinal stabilization.
Right. So you don't want to make it worse.
Exactly.
But there's a question about when you shouldn't do a log roll. Why would that ever be the case?
It all comes down to spinal stability.
Okay.
If the patient has an unstable spinal injury, moving them with a log roll could actually make things worse.
Oh, really? Why?
So imagine a spinal column with a fracture that isn't properly stabilized. Any twisting or movement during the log roll could shift the bones.
Right.
Potentially putting pressure on the spinal cord.
Okay.
Or even severing it completely.
Yikes.
That's a scary thought.
Yeah.
So if you can't log roll them, it depends on the situation and the resources that are available.
Yeah.
You might need a specialized backboard or even the help of a surgical team to stabilize the spine before the patient can be safely moved.
Okay, that makes sense. Now, let's shift gears a bit and talk about shock. You know, you have a lot of material on the different types of shock. Hypovolemic, cardiogenic, neurogenic.
Right.
And there are a lot of questions about recognizing the signs and symptoms of each. Like, for instance, there's that case study about the restless trauma patient.
Right.
What are some early signs that someone might be in shock?
So shock is a life-threatening condition.
Yeah.
Occurs when the body's tissues and organs don't get enough blood flow and oxygen.
Okay.
And as you mentioned, there are different types of shock.
Right.
But they all share some common signs, especially in those early stages.
So regardless of what's causing it,
yes,
there are some telltale signs.
Exactly. And one of the earliest and most subtle signs is a narrowed pulse pressure.
Oh, interesting.
Meaning the difference between the systolic and diastolic blood pressure readings gets smaller.
Okay.
So it's a sign that the body's trying to compensate for low blood volume or poor circulation.
So it's not just about the blood pressure numbers themselves. It's the difference between them that matters.
Yeah. Exactly. You could have a patient that seems like they have a normal blood pressure.
Right.
But if the pulse pressure is narrow, it could be a sign that shock is developing.
Got it. So what else should we be looking for in those early stages?
So restlessness or anxiety is a common early sign.
Okay.
Because this is the body's response to the stress of decreased blood flow and oxygen.
Makes sense.
So you often see an increased heart rate or tachycardia as the heart tries to pump harder to compensate.
Yeah.
And the patient's respiratory rate might also be elevated, or tachypnea, as they try to bring in more oxygen.
Okay.
Their skin might become cool and clammy to the touch.
Right.
Because the body is trying to shunt blood away from the extremities and towards the vital organs.
So the body's just going into overdrive.
Precisely.
Trying to compensate.
Exactly.
And those are the outward signs of that struggle.
Exactly.
So then that's where it's really important to know the different types of shock.
Right, because the treatment will be different.
Right.
Depending on what's causing it.
Can you give me an example of how that might be different?
Sure. Let's consider hypovolemic shock.
Okay.
Which is caused by loss of blood volume.
Right.
As you might see in a bleeding patient.
Yep.
The first priority is to stop the bleeding.
Makes sense.
Then we replace the lost fluids with intravenous fluids and potentially blood transfusions, but with cardiogenic shock.
Right.
Which is caused by the heart's inability to pump effectively.
Okay.
Simply giving fluids might actually worsen the problem by overloading the heart.
Okay.
Instead, you might need medications to improve heart function and possibly interventions like a cardiac catheterization or even surgery.
So the same symptoms could have totally different causes and require totally different treatments.
Exactly.
Yeah.
That's why a thorough assessment is so crucial.
Right.
We need to gather as much information as possible to figure out what's causing the shock and how to address it.
Okay, let's move on to something else that you sent over a lot of material about.
Sure.
Which is burns. I saw you had a case study about a 27-year-old male in respiratory distress after a house fire.
Yes.
Burns are scary.
They certainly are, and they present unique challenges.
Yeah.
Your materials are right to highlight fluid resuscitation as a cornerstone of burn care.
Right.
Yeah.
There's a question, though, about how do you even calculate the correct fluid rate when you don't even know how extensive the burns are yet?
Right. In a real-life scenario.
Yeah, especially in the field.
When time is of the essence, we don't always have time to calculate the total body surface area affected by burns precisely.
So how do you even know how much to give?
We use formulas based on the patient's weight and the severity of the burn, like the Parkland formula. But when we don't know the TBSA, we often start with a high flow rate of fluids and then adjust based on the patient's response.
So you start aggressively,
Yeah.
and then you just kind of play it by ear.
Exactly. It's better to err on the side of giving too much fluid initially than giving too little. We can always adjust the rate later based on the patient's urine output, vital signs, and other clinical indicators.
That makes sense. And I see there's also a question about when to send a burn patient to a burn center.
Yes.
So when do you make that call?
Not all burns require transfer to a burn center.
Okay.
There are specific guidelines that help us make that decision.
Right.
Burns that cover a large percentage of the body. Burns that involve the face, hands, feet, genitals, or major joints.
Okay.
And any burn that involves inhalation injuries are all considered high risk.
Right.
And usually require specialized care at a burn center.
Are there any other criteria?
Yeah, patients with pre-existing conditions like diabetes or heart disease that could complicate their burn care would also be considered for transfer.
Okay.
So it's a judgment call based on the individual patient and the resources available.
So it's not just the size of the burn,
Right.
but also where it is and the overall health of the patient.
Absolutely.
Okay, got it. Another topic that seems pretty challenging is thoracic trauma.
Okay.
I saw a question about how to tell the difference between a tension pneumothorax and a simple pneumothorax.
Right.
And those sound kind of similar to me.
Yeah, they do have similarities.
Yeah.
But the difference is critical.
Right.
A tension pneumothorax is a life-threatening emergency that requires immediate intervention.
So tension pneumothorax, bad.
Yes.
Okay.
So the main difference is that both involve air leaking into the pleural space, which is the area between the lungs and the chest wall.
Right.
But in a tension pneumothorax, the air can't escape.
So it just keeps building up.
Exactly, and it puts pressure on the lung.
Okay.
And eventually it pushes the heart and great vessels over to the opposite side of the chest.
Oh, wow.
And that compression can lead to circulatory collapse.
Yikes. So how do you even know if it's a tension pneumothorax?
So you'll see tracheal deviation,
Okay.
where the trachea or windpipe is pushed away from the affected side as the pressure builds up. You'll also hear absent breath sounds on that side
Okay.
because the lung is collapsed.
Right.
The patient will be in respiratory distress, struggling to breathe.
Makes sense.
Their blood pressure will drop.
Okay.
And you might see their neck veins becoming distended.
So if you see that tracheal deviation and those absent breath sounds,
Yeah,
that's a major red flag.
absolutely. It means you need to act fast.
Got it. What about a simple pneumothorax? How is that different?
So a simple pneumothorax,
Yeah.
while still serious, usually isn't as immediately life-threatening.
Okay.
The patient might have chest pain and shortness of breath.
Right.
And you'll hear diminished breath sounds on the affected side.
Okay.
But their trachea will typically stay midline,
Okay.
and their blood pressure will generally remain stable.
So it's the key to watch for those signs of pressure building up,
Exactly.
like that tracheal deviation, the absent breath sounds,
Right.
and a rapidly declining blood pressure.
Exactly. Early recognition is key to saving lives.
And that brings us back to that case study we mentioned earlier
Yes.
about the patient who had that large open chest wound after being attacked with a machete.
Right.
I can see why that's a really high priority situation.
Definitely. An open chest wound can easily lead to a pneumothorax.
Okay.
And if it's not sealed properly, it can progress to a tension pneumothorax very quickly.
Oh, wow. So knowing how to manage these types of injuries is really essential
For both the
exam and for real life.
Yes, this is where those critical thinking skills really come in.
Right.
You need to be able to assess the situation quickly,
Yeah.
identify the problem,
Right.
and initiate the appropriate interventions without hesitation.
Well, let's move away from the chest for a second and talk about musculoskeletal injuries.
Okay.
You know, they're super common in trauma.
Right.
And one of your questions described a patient with a lower extremity fracture who develops severe pain and tightness in his calf.
Oh.
That doesn't sound good.
You're right to be concerned.
Yeah. That description is classic for compartment syndrome.
Okay, what is that?
It's a serious complication that can occur after a fracture.
Right.
And it occurs when pressure increases within a muscle compartment.
Oh, okay.
Muscle compartments are groups of muscles that are enclosed by tough fascia.
Okay.
Kind of connective tissue.
Right.
And that increased pressure can cut off blood flow to the muscles and nerves.
Oh, so it's like the fascia is like a tourniquet.
That's a good way to visualize it.
Yeah.
And the classic signs of compartment syndrome are known as the 5P: pain, pallor, paresthesia, paralysis, and pulselessness.
Oh, okay. So if someone's complaining of a lot of pain,
Yes.
that seems out of proportion.
Especially if the pain isn't relieved by medication.
Right.
And it's accompanied by other signs.
Right.
Like swelling, deepness, and changes in sensation.
Got it. So that's a red flag.
Yes, absolutely.
Okay, I'm making a mental note of that.
Good.
Now, moving up to the head, let's talk about brain injuries.
Your Quizlet set has a question about tearing of the bridging veins and subdural hematoma.
Yes.
Can you break that down for me?
So the bridging veins are delicate blood vessels that connect the brain surface to the dura mater, which is the outermost layer of the meninges, the membranes that surround the brain and spinal cord.
Right.
A subdural hematoma happens when these veins tear, usually due to a blow to the head,
Right.
and blood starts to collect between the dura mater and the brain.
So it's like inside the skull but outside the brain.
Exactly.
Okay.
And it's important to be able to distinguish subdural hematomas from other types of brain injuries,
Right.
like epidural hematomas, which happen between the skull and the dura mater,
Okay.
and diffuse axonal injury, which is widespread damage to the brain's nerve fibers.
Yeah, they all have different characteristics and different treatments.
Exactly.
Speaking of that, there's a question about late signs of increased intracranial pressure. Why are those so important to recognize?
So increased intracranial pressure, or ICP,
occurs when there's swelling or bleeding inside the skull.
Right.
And that pressure starts to push on the brain.
Okay.
If it gets too high, it can compress vital brain structures,
Right.
leading to permanent brain damage or even death.
Oh, wow.
Early signs of ICP can be subtle,
Okay.
but as that pressure increases, you see more obvious signs, like a decreased level of consciousness,
Okay.
a slowing heart rate, irregular breathing, and fixed and dilated pupils.
So the body is giving off these warning signs
Yeah.
that something's really wrong.
And the later those signs appear,
Yeah.
the more serious the situation is likely to be.
Right.
So recognizing and addressing ICP early is crucial
Right.
to preventing further damage.
Okay, I'm definitely going to be paying attention to those signs.
Good.
Now, one thing that stood out to me in your material is the emphasis on geriatric trauma.
Right?
Why are older trauma patients different?
That's a great question.
Yeah.
So as we age, our bodies go through physiological changes.
That make us more vulnerable to injuries
Okay.
and can complicate recovery.
Makes sense.
So, for example, our bones become thinner and more brittle, increasing the risk of fractures even from minor falls.
Oh, yeah.
Our skin thins and loses elasticity,
Right.
making it more prone to tearing and bruising.
Okay.
And our organs, well, they just don't function as efficiently as they used to,
Right.
making it harder to tolerate the stress of an injury.
So an injury that might be no big deal
Right.
for someone younger
Yes.
could be really serious for an older person.
Exactly.
Right.
So that's why it's so important to approach geriatric trauma patients with an awareness of their unique needs.
So you have to adjust your assessment techniques.
Exactly.
You have to think about.
You might need to take into account things like age-related hearing loss or cognitive impairment.
Right.
Be mindful of potential complications like pneumonia or delirium, which are more common in older adults.
Right. So they're not just younger adults with wrinkles. They have their own specific considerations.
Right.
And that brings us to our last topic for this part of the deep dive,
Okay.
which is disaster triage.
Right.
You have a question about applying triage principles to a patient with bilateral femoral fractures in a disaster scenario.
Yes.
So walk me through that.
So disaster triage is all about prioritizing care.
Right.
When you have more patients than you have resources, the goal is to do the greatest good for the greatest number of people.
Makes sense.
To do that, we use triage systems like START, which stands for Simple Triage and Rapid Treatment.
Okay.
It's a simple color-coded system that helps us quickly assess patients and categorize them based on the severity of their injuries
Right.
and their chances of survival.
Okay.
So patients are tagged with different colors. Red for immediate, yellow for delayed, green for minor, and black for expectant.
So red means they need help now.
Yes.
Yellow means they can wait a bit.
Right.
Green means they're walking wounded.
Exactly.
And black means not good.
That's a simplified way to put it, but it captures the main idea.
Right.
So in the case of your patient with the bilateral femoral fractures, the triage category would depend on a few factors.
Okay, like what?
Well, first, we'd need to assess their airway, breathing, and circulation.
Okay, just like in any trauma.
Just like in any trauma situation.
Right.
If they have a compromised airway or are struggling to breathe, they'd be categorized as red regardless of those fractures.
Okay.
But if their ABCs are stable, then we'd look at the severity of their bleeding.
Okay.
If they have uncontrolled bleeding, they're also red.
Right.
But if their bleeding is controlled, we'd then assess their mental status.
So you're starting with the most life-threatening things.
Exactly.
And working your way down.
Exactly. And with bilateral femoral fractures, if the patient is alert and oriented, their triage category would likely be yellow.
Okay.
Meaning they need urgent care.
Right.
But they're not in immediate danger of dying. Okay. But if they're unconscious or have altered mental status, they'd be categorized as red.
So even though their injuries sound really bad,
right,
they might not be the highest priority
in
a mass casualty situation.
It can be a difficult concept to grasp, right, because we're trained to focus on each individual patient.
Yeah, that makes sense.
But in a disaster, you have to consider the big picture.
Right.
Make tough decisions about who gets treated first.
Right.
Based on their likelihood of survival and the resources available.
That's a huge responsibility.
It definitely is.
Yeah.
That's why understanding these triage systems and practicing them, even in simulations, is so important.
Yeah.
So you're prepared to make quick and effective decisions.
Okay, well, that was a lot of information.
Yeah.
Maybe we should take a break.
Sounds good.
And pick up the rest of this stuff in part 2.
Great idea.
All right, we're back, ready to dive into some more of these TNCC prep materials.
Sounds good.
This stuff is intense, but I'm starting to feel like I'm getting it.
Trauma nursing is a challenging field, but it's also really rewarding.
Yeah.
You're dealing with these life or death situations, making really critical decisions on the fly.
Yeah, and that disaster triage is a huge responsibility.
Absolutely, and it's important to remember that triage decisions aren't set in stone.
Okay.
Things can change quickly in a disaster.
Right.
And as more resources become available or as the situation evolves, patient categories might need to be reassessed.
So you're constantly evaluating and reevaluating.
It's a dynamic process.
Okay, so speaking of evaluating, I noticed one of your Quizlet questions mentions pulse oximetry and capnography as monitoring parameters.
Right.
What's the difference between those two?
Okay, so they're both essential tools for assessing a trauma patient's respiratory status, but they give us different pieces of the puzzle. So pulse oximetry, which is that little clip they usually put on your finger, measures the oxygen saturation of your blood.
Okay.
It tells us how much oxygen is bound to the red blood cells.
So it's basically telling you if they're getting enough oxygen.
It's a quick and non-invasive way to check that,
Okay, and what about capnography?
So capnography measures the carbon dioxide level or CO2 level in the patient's exhaled breath.
Interesting.
It's a bit more sophisticated than pulse oximetry.
Okay.
And it gives us a more complete picture of ventilation.
So pulse ox is oxygen in.
Yes.
And capnography is carbon dioxide out.
Exactly. And by using those two together, we can get a really good idea of what's going on with the patient's respiratory status.
And make better decisions.
And guide our interventions.
Okay, that makes sense.
For example, if a patient has a low pulse ox reading, it could mean they're not getting enough oxygen, maybe because of a lung injury or an airway obstruction.
Okay.
And if they have high capnography readings, it could indicate that they're not breathing effectively.
Okay.
Maybe because of a chest injury or respiratory depression from medications.
So much information from those two little numbers.
It really is. Technology has really revolutionized trauma care.
Yeah.
And these monitoring tools allow us to make more informed decisions and intervene more effectively.
Okay, speaking of interventions, there's a question about this March mnemonic. What is that and how does that work?
So MARCH stands for massive hemorrhage, airway, respiration, circulation, and hypothermia.
Okay.
It's a memory aid.
Right.
That helps us remember the order in which we should address life-threatening injuries in a trauma patient.
Right. So it's like ABCs.
Very similar, yeah.
Massive hemorrhage first.
That's the top priority, absolutely.
And that's where that narrowed pulse pressure can be a really early sign.
Exactly.
That something's wrong.
So first, we control any major bleeding.
Okay.
We make sure the airway's open and the patient is breathing adequately. We assess their circulation, check their heart rate, blood pressure, capillary refill.
Okay.
And finally, we address hypothermia,
Right.
which can make bleeding worse and disrupt the body's ability to clot.
So you're just going step by step.
It's a systematic approach.
And making sure you don't miss anything.
Exactly, but keeping in mind that everything's interconnected.
Right. And speaking of interconnectedness,
Yeah.
I saw this question that linked positive pressure ventilation to like making a pneumothorax worse.
Oh, interesting.
How are those two things related?
So positive pressure ventilation, or PPV, is a technique that we use to help patients breathe when they can't do it effectively on their own.
Yeah.
So it involves using a bag valve mask or a mechanical ventilator to force air into the lungs.
Right.
But in a patient who already has a pneumothorax, remember that's air leaking into the pleural space.
Yeah.
PPV can actually make things worse by pushing more air into that space.
Oh, so you're just making the hole in the lung bigger.
That's a great way to think about it, yeah.
Okay.
So that's why it's so important to be aware of the possibility of a pneumothorax.
Right.
Especially in trauma patients.
Yeah.
And to monitor them closely when we're using PPV.
So what would you do if you were using PPV and noticed the patient was getting worse?
That would call for immediate reassessment.
Right.
You'd want to listen to their breath sounds. Check their vital signs, look for signs of a tension pneumothorax.
Right.
Like tracheal deviation, absent breath sounds.
Right.
If you suspect a tension pneumothorax, you'd need to perform a needle decompression.
A needle decompression. What is that?
It's a potentially life-saving procedure.
Okay.
You're basically inserting a large bore needle into the chest cavity to release the trapped air.
Okay. That's intense.
It is, but it's a procedure you'll definitely want to know for the
TNCC
TNCC exam.
Okay, so let's go back up to the head for a second and talk about brain injuries again.
Okay.
You know, we talked about that subdural hematoma earlier.
Mm-hmm.
What's the difference between that and an epidural hematoma?
So they both involve bleeding inside the skull, but they occur in different locations and have different characteristics. So a subdural hematoma is a collection of blood between the dura mater and the brain, usually caused by tearing of those bridging veins.
Right, and that's more of a slow bleed.
These bleeds tend to be slower,
Yeah.
And the symptoms might not show up immediately.
So it's insidious.
You could say that.
Okay.
And the symptoms can vary a lot depending on the size of the bleed and how quickly it's developing.
Okay.
Some common signs are headache, confusion, drowsiness, and weakness.
Okay, and what about epidural hematoma?
So an epidural hematoma is bleeding between the skull and the dura mater, usually caused by a tear in the middle meningeal artery, which runs along the inside of the skull.
Okay.
And these bleeds tend to be fast and more dramatic.
Right.
Often with a classic presentation where the patient loses consciousness briefly. Then they have a lucid interval where they seem alert.
Oh, wow.
And then there's a rapid decline in their neurological status.
So it's like a bomb went off.
It can be that sudden and severe, yes.
Okay.
It's a surgical emergency.
So subdural, slow.
Yes.
Epidural, fast.
Exactly.
Got it.
Very good.
I also saw a question about one of those late signs of increased intracranial pressure called Cushing's response.
Mm-hmm.
What is that?
So Cushing's response, also known as Cushing's triad, is a set of 3 signs that indicate dangerously high pressure inside the skull.
Okay.
So those signs are bradycardia, which is a slow heart rate, irregular breathing, often with periods of apnea and hypertension or high blood pressure, with a widening pulse pressure.
Wait, widening?
Yes.
I thought narrowing was a sign of shock.
You're right. Narrowing is usually what we see in shock.
Okay.
But Cushing's response is different.
Okay.
It's the body's last-ditch effort to keep blood flowing to the brain.
Oh.
Okay.
When that pressure inside the skull is really high.
Okay, so it's like a reflex.
It's a reflex mechanism, yeah.
Got it.
But unfortunately, it's a very late sign.
Okay.
And often means that the brain is herniating.
Oh, no.
Which is life-threatening.
So if you see those 3 signs together, you know it's bad news.
Absolutely.
Yeah.
It's a critical situation that requires immediate intervention.
Okay, let's get back to the geriatric trauma.
Okay.
You mentioned earlier that older adults are more vulnerable
Yes.
to injuries and more likely to have complications.
Right.
Can you tell me more about that?
Sure. So as we age,
Yeah.
our organs just don't function as efficiently.
Right.
Our heart and lungs have less reserve.
Okay.
Our kidneys filter blood more slowly.
Mm-hmm.
And our immune systems just aren't as robust.
Right.
So all of this means that older adults are less able to tolerate that physiological stress of an injury.
Okay.
They're more likely to develop complications,
Right.
like pneumonia, sepsis, and organ failure. So it's not just the injury itself.
Exactly.
It's how their bodies react to it.
That makes a big difference.
Right. What are some other things we should think about when caring for an older trauma patient?
So their medication list
Oh, yeah.
is really important.
Yeah.
Older adults often take multiple medications,
Right.
and some of those can interact with the medications that we use in trauma care
Right.
and cause complications.
Yeah.
For example, blood thinners,
Okay.
which are common for preventing strokes,
Uh-huh.
can increase the risk of bleeding
Right.
after an injury.
Makes sense.
So getting a detailed medication history is really crucial.
Okay. It's about seeing the whole patient,
It really is.
not just the injury.
Exactly.
I saw one of your Quizlet questions mentioned a history of falls
Yes.
as an important factor in geriatric trauma.
It is.
Why is that?
So falls are the leading cause of injury and death in older adults.
Really?
And a history of falls can be a sign that something else is going on. Maybe a balance problem, vision impairment, or a medication side effect.
Right.
We need to figure out what's causing those falls
Right.
and address the underlying problem.
So falls are a major concern.
Absolutely.
Yeah. And I imagine head injuries
Yes.
are particularly worrisome in older adults.
They are. Head injuries are a leading cause of death and disability in older adults.
Yeah.
And even what seem like minor head injuries can have serious consequences.
Oh, wow.
So we need to have a high index of suspicion for head injury
Right.
in any older adult who has fallen or experienced any other trauma,
Yeah.
even if they don't have obvious signs or symptoms.
Okay, so better safe than sorry.
Right.
Get a head CT scan.
In many cases, yes.
Okay.
A CT scan can help rule out serious brain injuries,
Right.
like a subdural hematoma,
Yeah.
and that can help us make more informed treatment decisions.
Okay. I'm keeping that in mind. Now let's shift gears again and talk more about shock.
Okay.
We've already covered the different types of shock, but I have a question about this stage of shock called decompensated shock.
Okay.
What's happening at that point?
So decompensated shock is the point where the body's compensatory mechanisms start to fail.
Okay.
It means that the patient is moving closer to irreversible shock,
Okay.
which ultimately leads to death.
Right.
So in those earlier stages, compensated and progressive shock,
Mm-hmm.
the body is working really hard to maintain blood flow to the vital organs.
Right.
It does this by increasing heart rate,
Okay.
constricting blood vessels,
Mm-hmm.
and shunting blood away from the less essential areas.
So the body's putting up a fight,
Exactly.
but it's starting to lose.
Yeah, and in decompensated shock, the
Uh-huh.
signs and symptoms become much more severe.
Okay.
The patient's blood pressure will drop significantly.
Right.
Their heart rate will become weak and thready.
Okay.
Their breathing will be labored, and their mental status will deteriorate.
Oh, wow.
They may become confused,
Right.
disoriented, or even unresponsive.
So you're running out of time.
Yes, it's a critical situation.
Yeah.
Requires immediate, aggressive intervention.
So what are the key interventions at that stage?
So the goal is to restore adequate blood flow and oxygen delivery to the tissues and organs.
Right. So you're trying to support the body.
Exactly.
Right.
That might involve intravenous fluids and blood transfusions to increase blood volume,
Okay.
medications to help the heart pump better and constrict the blood vessels,
Mhm.
and providing supplemental oxygen or mechanical ventilation
Okay.
to support breathing.
So you're coming at it from every angle.
Exactly. The sooner we can intervene and reverse the shock, the better the chances of survival.
Yeah, I'm really starting to see the big picture here.
Good.
It's not just about knowing the individual facts.
Right.
It's about understanding how it all works together
Exactly.
and how to use it.
And that's what the TNCC exam is all about.
Right.
They want to make sure you're not just a walking textbook,
Right.
but a critical thinker
Right.
who can analyze situations,
Right.
make good judgments,
Yeah.
and act decisively when faced with a trauma emergency.
Well, I'm feeling a lot more prepared for this exam thanks to your help.
Oh, that's good to hear.
Are there any other topics that you think we should cover before we move on to the last part of this deep dive?
Let's think. We've covered the trauma triad of death, airway management, spinal cord injuries,
Right.
shock management, burns,
Yeah.
thoracic trauma, musculoskeletal injuries, head injuries, geriatric trauma, disaster triage.
A lot.
Monitoring parameters, the March mnemonic.
Yeah.
Positive pressure ventilation, different types of brain bleeds.
Right.
Increased intracranial pressure, stages of shock.
Yeah.
And the unique considerations for older trauma patients.
You're like a walking encyclopedia.
It's all about connecting the dots and understanding how it all fits together. You're doing great.
Thank you.
Asking really insightful questions.
Well, I'm still learning, but I'm getting there.
Good.
But I think my brain could use a little break.
Yeah, me too.
Before we tackle the last part of this material.
Sounds good.
So let's pick up where we left off in part 3. Okay, we're back for the final part of our deep dive. I feel like my brain is about to explode, but in a good way.
It's good to be challenged, right?
Exactly.
No.
And you helped me really understand this stuff, so...
Well, that's the goal.
Yeah, I'm not just memorizing flashcards. I'm actually understanding how to apply this stuff.
Absolutely, and that's what's going to help you on the exam.
Okay, so are there any other, like, really tricky concepts that we need to cover?
You know, there are a few more interesting questions.
Okay.
In your Quizlet sets. I saw one that I thought was really relevant to real-life trauma nursing.
Yeah.
It's about a trauma patient coming into a rural ED.
Okay.
But the CT scanner is down.
Oh, that's a nightmare scenario.
It is. It's a real challenge.
Yeah.
But it's the kind of scenario that really tests a trauma team's ability to think on their feet.
Right.
Your study materials really emphasize the importance of huddling in this situation.
Huddling. Like a football team.
Well, kind of.
Okay.
In the trauma context, it means the team comes together quickly.
Okay.
Share information, anticipate problems, and adjust their plan.
Okay.
They might need to think about transferring the patient to a different facility that has a working CT scanner.
Right.
Or they might have to rely on other diagnostic tools and their clinical judgment to guide their decisions.
So you have to be flexible.
Adaptability is a key skill for a trauma nurse.
Yeah. Oh, that makes sense.
Good.
Here's another question that kind of threw me off.
Okay.
What happens when a patient has a suspected spinal cord injury, but they still have reflexes below the level of the injury?
It seems counterintuitive, right?
Yeah. Shouldn't those be gone?
It's not always the case.
Okay.
A spinal cord injury doesn't always mean that the cord is completely severed.
Okay.
It could be compressed,
Right.
bruised, or partially damaged.
Yeah.
Which means that some of those nerve signals are still getting...
So those reflexes below the injury are actually a good thing?
Well, they can help us understand the severity of the injury.
Okay.
Intact reflexes might suggest a less severe injury.
Okay.
And a better chance of recovery.
Okay.
But we never rely on just one finding.
No.
It's always about putting all the pieces of the puzzle together.
Right.
The exam findings, the imaging studies, and the patient's neurological status as it evolves.
Got it. Teamwork even inside the body.
Exactly.
Okay. What about burns?
Okay.
There's that question about calculating the total body surface area affected by the burn. Is that where that rule of nines comes in?
You got it.
Okay.
The rule of nines is a quick and easy way to estimate that burn area,
Okay.
which is especially important in those first few minutes of burn care.
Okay.
It helps us figure out how much fluid resuscitation the patient needs.
Right.
So we divide the body up into sections, and each section represents about 9% of the total body surface area.
Okay, so how does that work?
So the head and neck together make up 9%.
Oh.
Each arm is 9%.
Right.
Each leg is 18%. That's 9 for the front and 9 for the back.
Okay.
The front of the torso, or the anterior trunk, is 18. The back, or the posterior trunk, is 18.
Okay.
And the genitals make up that last 1%.
Okay, so if someone has burns on their entire arm and the front of their chest, that would be...
So the arm is 9% plus 18 for the anterior
So
trunk.
27%.
Exactly.
Wow.
It's a simple system.
Yeah?
But it's really useful in those initial moments of a burn emergency.
Okay, I'm definitely picturing those nines now on a person,
Good.
if I need to estimate that.
Good.
There's this question that seems a little out of left field.
Okay.
What is the factor that contributes most to the kinetic energy of a moving body?
Physics.
I'm not sure I see how this relates to trauma.
It might seem random,
Yeah.
but understanding kinetic energy is actually a fundamental concept in trauma care.
Okay.
Kinetic energy is the energy of motion, and it plays a big role in how severe injuries are.
Right.
And the answer to that question is velocity or speed.
So the faster something is moving,
Yes.
the more energy it has.
The more kinetic energy it has. Exactly.
Okay. And that makes sense when you're talking about car crashes.
Exactly. Because a car traveling at a high speed has a lot of kinetic energy.
Right.
And when it hits something, that energy has to go somewhere.
Right. It's not just disappearing.
It gets transferred to the vehicle itself, to the people inside the car, and to their internal organs.
That's why we always ask about the speed that they were going.
It helps us understand the mechanism of injury.
Okay. And you mentioned those car crashes.
Mm-hmm.
And I remember my study material mentioned 3 impacts involved in a car crash.
Yes, it's not just about the impact of the car hitting something.
Right.
It's also about the occupants of the car hitting the inside of the car.
Right.
And their internal organs hitting the inside of their bodies.
Oh, wow.
So we call these the 3 collisions.
Okay.
So the first impact is the vehicle hitting an object.
Okay.
Whether that's another vehicle, a tree, a wall.
Right.
The second impact is the occupants inside the car hitting the dashboard, the steering wheel, the windshield.
Right.
And then the third impact is the internal organs hitting the inside of the body.
Okay.
So the brain hitting the skull,
right,
the heart hitting the rib cage, things like that.
So it's a chain reaction through the body.
And understanding these 3 collisions helps us anticipate what kinds of injuries we might see.
Okay.
For example, in that first impact, we might see injuries to the extremities, like leg fractures or pelvic fractures from the force of the collision.
Okay.
In that second impact, we often see head injuries.
Right, because they're hitting the dashboard.
Injuries.
Abdominal injuries because they're hitting the inside of the car.
Okay, and then that third impact is all the internal stuff. Exactly. So we would look for internal bleeding, organ damage, things like that.
Wow. It's amazing how much damage can happen in just a few seconds.
It is incredible the forces involved in these high-impact collisions.
Yeah, and there was a question about that third impact and a specific injury that can happen.
Yes.
Do you have an example of that?
Sure. One classic example is an aortic tear.
Okay.
So the aorta is the largest artery in the body.
Right.
And it's anchored to the spine by a ligament.
Okay.
When there's sudden deceleration, like in a high-speed car crash, the aorta can be torn.
Oh, wow.
At that point of attachment.
Yeah.
And that can cause massive internal bleeding.
So even if they look okay on the outside,
exactly,
it could be really bad on the inside.
It's important to remember that those internal injuries aren't always visible.
Right.
We need to have a high index of suspicion, especially in those high-speed crashes.
Okay. Well, I'm definitely keeping that in mind. I had a question about a pelvic fracture, and my material talked about pelvic instability.
Yes.
What's so bad about an unstable pelvis?
So pelvic instability means the bones of the pelvis are no longer properly aligned.
Okay.
So ligaments are torn, the bones are out of place.
Right.
It's a serious injury that can cause major bleeding and other complications.
So it's more than just a broken pelvis.
It is. The pelvis is a very vascular area.
Okay.
It has a lot of blood vessels.
Right.
So when there's a pelvic fracture, there's a risk of serious bleeding.
Right.
And if the pelvis is unstable, it's much harder to control that bleeding.
That makes sense why there was a question about using a pelvic binder.
Yes. The pelvic binder is a really important tool in managing these types of injuries.
Right, it's like a giant tourniquet.
It helps stabilize the fracture, compress those bleeding vessels, which gives them a better chance to form clots.
So that can be really life-saving.
Pelvic binders can be life-saving.
Okay, so pelvic instability, bad.
Yes.
Pelvic binder, good. Got it.
Yeah.
What about a Smith fracture? What's that?
Okay, so a Smith fracture is a fracture of the distal radius. That's the bone in the forearm that connects to the wrist.
Right.
But what makes it unique is that the broken piece of bone is angled towards the palm.
So it's like a backwards Cauls fracture.
You could think of it that way.
Okay.
So a Cauls fracture is also a fracture of the distal radius, but the broken piece is angled backward toward the back of the hand.
Okay.
So the difference in how that bone is displaced can affect the treatment and how well it heals.
Okay, so those little details really matter.
They do, just like that question about the teardrop-shaped pupil.
Right. Why is that so much worse?
So a teardrop-shaped pupil is a sign that the eyeball itself has ruptured.
Oh, wow.
It means there's serious damage to the eye.
Yeah.
It's a surgical emergency.
Okay, I won't forget that one.
Good.
I'm glad there was also a question about something that's good to see. What's the best thing to see in a guy with hip pain after a fall?
The best thing to see is a stable pelvis.
Okay.
If the pelvis is stable, it means there's less likely to be a serious fracture.
Okay.
And all those complications that come with it.
Stable, good.
Stable, good.
Got it.
All right.
Last one, what about elevated creatine kinase?
Okay, so creatine kinase, or CK, is an enzyme that's found in muscle.
Right.
And when muscle is damaged, CK levels go up in the blood.
Okay.
So a high CK level tells us there's muscle breakdown happening somewhere.
Okay.
It could be from a direct blow, a crush injury, or even from being immobile for a long time.
Interesting.
Yeah.
Okay, well, taking all of this information together, my brain is full, but I'm really glad we did this because I feel like I'm not just memorizing facts anymore.
That's good.
I'm understanding how to use it.
Good. The goal of all this studying is to be able to provide the best possible care for your trauma patients.
Well,
it sounds like you're on the right track.
Well, I feel a lot more confident now thanks to your help.
I'm glad to hear it.
And I'm ready to take this TNCC exam.
Good luck. I know you'll do great.
Thanks. And to all of you listening out there, good luck to you too.
You got this.
And remember, it's not just about passing an exam.
That's right.
It's about taking care of real people.
Absolutely.
You guys are going to be amazing.
You're going to do great things.